It looks like we're live on YouTube, so whenever you're ready.
Thank you. I'd just like to welcome everyone this morning to the Tees Valley Joint Health Scrutiny Committee meeting. It's Tuesday the 22nd of June, and as this is the first meeting of the municipal year, the first item on the agenda is the appointment of chair. I'd therefore like to invite nominations from the floor for a chair for this year, please. At the moment, it would seem that there is no nominations for a permanent chair. Obviously, I'm conscious that because of this meeting being held relatively early in the municipal year, not all members have been appointed from the various local authorities. So in this situation, we would need to appoint a pro tem chair just for this meeting. I'd therefore like to invite some nominations from the floor for a pro tem chair just to chair this meeting if possible, please.
Could I nominate Councillor Holoui, please?
Can I just confirm who that was with? Thank you. Sorry.
It was Councillor Cunningham. It's Councillor Alma Holoui.
No problem. That's great, Councillor Cunningham. Is there anyone that would second that nomination? Yeah, Councillor Layton. Is that okay?
Yes, thank you very much.
Okay. So that's lovely, thank you. So Councillor Lowry has been nominated as chair pro tem for this meeting. And I'll hand over to Councillor Lowry, please, for the nomination.
Thank you. Thank you for that. Then I will chair this meeting. Thank you for the nomination. Thank you for your support. Thanks, Caroline. So if we move to item 2 on the agenda, we have to nominate a vice chair, and that should be from Darlington, as I understand it. So we would need nominations from the Darlington group for the vice chair for next year. Have we any nominations for the vice chair from Darlington?
I think I'm the only person from Darlington. And I think we're missing Councillor Bell. I can't see him. I'm not sure if he's here. And I think we're awaiting one more to be confirmed. So I don't know whether it's possible to have somebody temporary. Caroline, is that okay?
Yeah, that's fine. If there would be anyone from another local authority that would be happy to nominate Councillor Layton as Vice Chair Pro Tem for this meeting, and someone who will be prepared to second that, that will be lovely. Thank you.
I would nominate, am I able to nominate Councillor Layton for the Pro Tem role as Vice Chair for this meeting?
You are, Chair.
Thank you. So we need a seconder for that, please. Have we got a seconder?
I will second.
Thank you. That's fine. Thank you. So we're sorted on the protocol thus far, although we have the protocol coming up later on. So we have apologies now as item 3. I do understand we have quite a few apologies, Caroline, is that right?
Yes, that's correct, Chair. We've got apologies from Councillor Clark and Councillor Smith at Redcar, and we've got apologies from Councillor Rob Cook at Hartlepool, and Councillor Bell at Darlington. Thank you, Chair.
Thank you, Caroline. And this is partly because all the councils haven't done their final selection of councillors to represent this their area on this committee. So thank you. Have we any declarations of interest this morning? I can't see any hands up. Can anyone else? Can you, Caroline, see any? No? Okay, I think we have no declarations of interest. That's item 4, so we'll progress to item 5. The minutes of the 19th. Caroline, do you want to talk about this?
Yes, thanks, Chair. Obviously, these are just the minutes from the last meeting that was held in March, and it's just for the committee to approve them today. Thank you, Chair.
Thank you. Would anyone like to approve the minutes? Raise their hand to approve the minutes as a true and correct record of the meeting we had then. Seems a long time ago. But I can't see a hand to approve the minutes.
Sorry, Councillor. Sorry, Chair. It might be just that there wasn't. I don't know whether there was any of the members, because we've had quite a lot of new members appointed to the Tees Valley Joint Health Scrutiny Committee. So I'm not sure whether the membership from that meeting is whether there's 2 members that were here. I think Councillor Cunningham. I don't know whether Councillor Cunningham was there at the last meeting, whether she's able to agree the minutes.
Yeah, I will agree the minutes.
Thank you, Councillor Cunningham. That's fine. Do we have any matters arising from these minutes, or do we just approve the minutes, Caroline, please?
Thank you, Chair. Okay,
fine. Thank you. So item 6 on that note is about the protocol for the Tees Valley Joint Health Scrutiny Committee. Made interesting reading, I thought. What do we need to do with this protocol? Is it to approve it, Caroline?
Yes, thank you, Chair. It's just to for the committee's information in terms of updating everyone.
Yes.
Yeah, and making everyone aware of what the requirements are for the Tees Valley Joint Health Scrutiny Committee. There is one amendment that I think needs to be made on there with the reference to the CCGs. I think it makes reference to the individual CCGs. Darlington, what was formerly Hartlepool and Stockton CCG and South Tees CCG, but those are now amalgamated to Tees Valley CCG. So I think that needs to be amended on the document.
Yes.
Before, it's approved. But otherwise, if members are happy with that, then that's just for their approval at today's meeting, Chair.
Okay, so can we have someone who would suggest that we approve this protocol with the amendment that Caroline just mentioned? And I saw Dominic was nodding there about the change in the way that structure's happened. So would someone like to approve that we have now the update, and we agree to that?
Agreed.
Thank you. Are we okay with that, Caroline? Is that what you require? Thank you. Okay, so item 7 on the agenda is the Tees Esconwea Valley NHS Foundation Trust, who is going to present the quality account between 20 and 21. And is that right that we have Avril here, Avril Lowry, Director of Quality Governance, and Dr. Chris Lanigan, Head of Planning and Business Development? It was a long document. I think it come to something like 80 something pages when it was all put together on the information we got. So are you going to present the highlights from this for us?
We are, Councillor Halloumi, and with your permission, I'll just share a very simple set of PowerPoint slides. Well, that will help talk it through.
Yeah, could I just ask before you start then, is it that as an outcome from this presentation you want us to give ideas that would formulate a response from this committee? Is that what we're trying to do exactly? That's what I understood.
Yes, Chair. Would expect members may have some questions, and there's actually 4 of us here from the trust who I'll introduce in a moment, and we'll do our best to answer those questions. But yes, what we would be looking for is the committee through yourself to basically this forms part of the formal consultation, so that you would write us a letter tonight or tomorrow summarising what you think is good about the quality account, but also anything that you're concerned about, and that you would, in a sense, anything you'd like us to think about more carefully.
That's fine. Thank you very much. So if we all have that in our minds as we watch the presentation, to be aware of what we find is good about this report and what concerns we may have. And as I understand it, the deadline is tomorrow, so it's a very short turnaround to get this letter compiled and sent in. So we need to think on our feet in the meeting as a group, but hopefully people have had time to put some thought into this since we got the document some time ago to look at individually. So is everyone okay with that suggestion that we have our thinking caps on as a group to put together our ideas? Would you like us to talk whilst you're presenting, or would you prefer that we write our notes down and talk at the end? I'm thinking that might be the better way in terms of timing, because we need to be aware of the time. And maybe if you present and we make our notes as a group to add to those we've already got, then we can move forward in that way. Does that meet with everyone's approval? Thank you. Thank you. So I'll hand over to you then, Chris, if I may call you Chris, to introduce.
Let's see. So hopefully members will be able to see a slide which says Chief Quality Account 2020-21.
Yes, we can. Thank you. That's fine.
Excellent. That's good news. So, that one. So just to say that the purpose of this presentation, as we were just discussing, is to, well, first of all, I do recognise some of the members of this committee are new to this. And so I'm going to say a little bit about TUV and about what on earth is a quality account anyway. and we're going to explain why we're doing this in June rather than April. I'm going to try and explain the connection between this and CHUV's new strategic framework, Our Journey to Change, and then we'll take you through the quality account document, which will help you formulate your questions and your opinions. So who's here from CHUV today? There's myself, Dr. Chris Lanigan, Head of Planning Business Development. There's Avril Lowry, Director of Quality Governance, who you're going to hear from in a moment. I think a number of you will have met Dominic Gardner before, who is our Director of Operations for Teesside, and you may also have met Sharon Salvin, who is our Head of Nursing for Teesside. But you'll be able to ask all of us questions at the end. So just for members who are new to this committee, Tees and Wear Valley basically is the NHS organisation that provides secondary mental health and learning disability care across Teesside, but also across Durham and Darlington and across North Yorkshire and York. And that's actually the way that we're organised. But Dominic and Sharon are here today, generally work across the 4 boroughs, but don't work in Darlington. We also have adult secure forensic care, which is based at Middlesbrough, and we also have people out working in prisons and in the criminal justice system as well. So we provide basically your mental health services. Quality accounts, they've been around for about a decade now. It's an annual report about the quality of services which all NHS healthcare organisations have to provide. They're meant to be about increasing public accountability, and as part of that is why we have to formally consult over in scrutiny committees to make sure that we have your views. In a sense, part of it's like a financial account, and it looks backwards at the year that's just finished. But also there's quality improvement initiatives which is looking forward, almost like a plan part of the document. As Councillor Halloumi said, some of the wording isn't always easy to digest, but unfortunately a lot of it is legally prescribed, and we have to do what the law says, whether it is easy to read or not. And part of the law is that we have to have 3, 4 or 5 quality improvement priorities. As you'll find out shortly, we have 3, but the 3 very wide-ranging ones. I also want to explain to members why we're doing this now, because in the past, this presentation has normally taken place in April, just before the end of the municipal year. Last year, it didn't happen at all because of COVID-19, and we were expecting this year that the deadlines for the quality account would be significantly slipped, and so we were thinking we would come a little bit later to you. But then on the 30th of April, the Department of Health decided that no, they were going to stick with the 30th of June legal deadline, and so we've had to accelerate our timetable. And we're extremely grateful to members of this committee for agreeing to meet so early in the municipal year, so that we actually can get your feedback. Our board of directors will consider that on Friday. And then we'll publish the final version of the plan next week. One of the things, some of you may have heard about CHUV's Journey to Change. We've got a new chief exec at CHUV, or relatively new, and I think we'd also recognise that we, as an organisation, we needed to find a new and different direction. So we spent a lot of time during last year engaging service users, carers, partners and staff in what we called a big conversation. We had plans to have all sorts of big meetings, but of course, as events transpired, 99% of it had to be done online. We all understand the reasons for that, I'm sure. And so we now have something called Our Journey to Change. That's a new mission, vision and set of values for the trust. You can see the values on the slide behind me. And in terms of our 3 new strategic goals, they are to improve service user and care experience, improve staff experience, and to be a great partner. And we think if we can get that right as an organisation, we'll be able to turn things around, and we'll be a much better organisation that delivers far better services to the people of Tees Valley and a far better partner to you, our local authorities. Obviously, we've also had extensive feedback from CQC, which is also fed into our proposals as well. And just to say as well, we're going to talk a lot about quality today, but if we can get the quality of our services right, that will in turn improve service user care experience, staff experience, and will help us be a great partner. So what I'm going to do now is I'm going to hand over to Avril, and Avril's going to tell me when to move the slides on. And Avril's just going to sort of, as because you've probably got the quality account in front of you, so we're just going to sort of briefly go through the main sections, and Avril may just want to say a few words in one or two places just to illustrate what the contents are.
Okay.
So Avril, I'll hand over to you.
Thank you, Chris. Yes. So in terms of the quality account, as Chris has mentioned, some of it is prescribed, and the actual framework is also prescribed. So part 1 will provide some information around the trust and our quality governance arrangement. So it's to provide you with an overview of that. And it goes on to give you a flavour of some of our key achievements around quality and safety over the previous financial year. Next slide, please, Chris. So in terms of part 2, there's a big focus on the progress made on the priorities that we identified previously, and giving you some detail on those key priorities. Some of them you will see, for example, making care plans more personal, for example, have been impacted by the COVID pandemic, and how we needed to really, put a command and control system in place and business continuity arrangements in the organisation to ensure that, all of our efforts were around maintaining patient safety and business continuity. And some of that actually meant moving staff around the organisation to ensure patients got the best possible care. And some of those staff were the people who were leading on some of this improvement work, where they've got very specialised roles in educating staff and developing some of our care processes and systems. So making care plans more personal was an area that was impacted upon, but you will see moving through the document that we're continuing with that as a priority for next year. And there's more information in that section around what we're specifically aiming to do to have that family and patient involvement in formulating those plans. There's something around, we had identified the transition of patients from children and young people services to adult mental health services, and that has actually developed quite significantly into something much more strategic than was originally planned in the quality account. And that's, I guess, one of the key areas within our business plan moving forward to look at that in a larger strategic way. So we will still continue to focus on that, and it's, I guess, broader in terms of its content. Reducing the number of preventable deaths. There's quite a bit of information in that section around some of the initiatives that we've undertaken, particularly around focusing on how we learn from death so that we can improve care for the future. That's really imperative in terms of, identifying when things go well, feeding that really good practice and sharing that across the organisation, as well as times when we might not have always got everything right, and there are areas and opportunities for improvement that we take really seriously. And in that narrative, you'll see lots of examples of the things that we've been focusing on and that we'll continue to do. One key area was, in terms of our patients' experience, was focusing upon the feeling of safety or feeling safe whilst an inpatient on our wards. And we have done quite some significant work. So I'm just going to invite Sharon, our head of nursing, to just talk a little bit and give you a bit of detail about what we've focused on and what we've achieved over the last year in this initiative.
Thank you, Avril, and thanks everybody. Yes, we have kind of looked at this metric because people often report to feeling unsafe on the wards, and we did try and do a deep dive into some of the reasons why and see if we could find out what we could do about it, I suppose. Often people would describe things like the environment. It could be other patients. It could be just coming into hospital in itself if they've never been into a mental health or learning disability hospital, can sometimes create their anxiety of safety. So we wanted to do some improvement work. So we involved kind of lots of the people who work within the wards, staff nurses, patients and carers, to look at how we could improve that. And we did submit some information just to the CCG as well, just to provide some added assurance of the work we are doing. So we did look at we created some ideas of how we could improve this. So things like having mutual help meetings with the patients and service users within our wards to really kind of understand on a regular basis of what we could do to change things for them, and make people feel safe. Things like ward orientation processes and inductions, you know, making sure people had keys for their bedrooms, making sure that people felt they understood what to do if things started to escalate on the ward from another patient, and how they could keep themselves safe. We also looked at things like staffing levels as well. So from our adult acute wards, that was where we found most of the responses as being kind of our patient experiences saying that patients didn't feel as safe. So we have done quite a bit of work around recruitment within our adult wards, making sure we've got the right amount of staff to be able to support the increased demands within our acute and patient services. And we used evidence-based tools such as host and the safe care modules that we have on our health rosters, just to make sure that we do it in an evidence-based way as well. I think we've also looked at initiatives such as Oxyhealth. So Oxyhealth is a sensory technology that we use to enhance safety, where we could it's like some technology that we use within patients' bedrooms that can monitor things like physical observations, your heartbeat, you know, can alert you when things aren't in the right kind of benchmarks for somebody's physical observations. And again, that will help people from a safety point of view, as well as work around looking at violence and aggression within our inpatient services as well, and working with the Royal College of Psychiatry and the Sexual Safety Collaborative as well, to look at improving how we manage sexual safety issues across our services. So lots of work going on. It's still ongoing. We're really focusing on that in terms of our adult wards when we're looking at our patient experience, and working with our service users and carers to make improvements. Yeah, thanks, Avril.
Okay, thank you. So moving on, pages 25 to 32 cover our quality improvement plans for the coming year, and we've got 3 key areas that we're going to focus on. The first one, again, is the continuation from last year about making care plans more personal. And there's a big focus here on the use of a tool called Dialogue, which we're implementing, which is it's a clinical tool that allows for personalisation of care planning. And we, you know, we're doing certain tests around how we will use it, but we see that as a fundamental tool to helping us achieve that aim of those care plans being more personalised, and the patient service user involvement in formulating those. So that those pages set out exactly what we are aiming to achieve over the course of the year in relation to that. There's a bigger focus around safe care, covered across pages 27 to 30. So you will see in there's a kind of visual diagram that highlights our approach. We're calling it our journey to safer care, and that links to our journey to change. So that strategic framework, and then we've got certain pieces of work that align to help us deliver those strategic goals and objectives. And our journey to safer care is one of those. It highlights 4 key areas: patient safety, that we're going to be working on in the coming year. And for each of those priorities, there will be associated work streams with measurable metrics, so that we're able to measure our progress as we go along and understand what we need to do differently. So you'll see that, you know, they focus on suicide prevention and reduction of self-harm. There's a focus around promoting the best physical health whilst in our care, harm reduction, which includes areas such as sexual safety, and then there are other areas around restrictive practices. So each one has a lead within the trust, a team of people who will be working on this, and it's the key thing is about how do we embed this at every level of the organisation so that we're all part of delivering it. So each individual understands their personal responsibility for providing safe care, no matter what that role may be in the organisation, and how that will play out in teams, in departments, in localities, and then up to the board. So we've got oversight of that. And it's very much about a journey of capturing the hearts and minds of people, and working with our service users to ensure that that journey is definitely underpinned by processes that will make care safer in the long run. And you can read some of the detail in the narrative. And then finally, compassionate care is kind of a combination of some of our previous priorities also, but it's very much focusing on the patient experience, how we use empathy and compassion, and how that, you know, the way we do things around here, it underpins how we care for patients. You may have seen some of the information that came from the big conversation that Chris referred to earlier, which was part of that consultation exercise when our new chief executive came into post. And there was a big emphasis on a system where sometimes process prevailed before people, and we really want to address that and, you know, be very clear about a person-centered approach which is underpinned by compassion and empathy, and that align with the values and the behaviours that we would expect to see our staff exhibit in terms of, you know, how they care for patients or how we interact with one another. So you can see again within that compassionate care, there are some examples of things that we'll be working on and how we'll know that we're making a difference. We've already undertaken some training with staff around empathy and compassion, which has been received really, really well and helped us to gain some new perspectives on the way that we would approach some of things such as our responses to complaints, working with patients where there may have been an incident, or just generally on caring for patients and tackling issues in a more compassionate way. So I think that's probably as much as detail as I was going to go into around those priorities. Happy to take any questions once the presentation's concluded around any of the detail. Part 2 continued, so the following pages then go on to look at key metrics that we identify on an annual basis that we're able to track our journey around quality and safety, and some of that data and is included across 3 domains of quality, which is patient safety, clinical effectiveness, and patient experience. And the next page. And then part 3 is generally, again, some mandated indicators that come from, I guess, the Department of Health that all trusts and mental health trusts should include within their account for the year. The metrics that we track ourselves, and some information around the single oversight framework. So very busy, lots of information in there, and you know, often takes quite a while to digest it. And I think we're trying to work more on how we can get some more easy read documentation in the future, so that this information is accessible to all and a wider audience. Okay, was that the last slide? Yeah.
Yes, that's the last slide.
It was. Okay, great. Thank you. Okay,
Thank you.
so I hope that's given you some insight into some of the work. Obviously, you know, a bit limited on the time we've got to discuss any of the detail, but happy to, we're all happy to take any questions.
Thank you very much, Avril, and thank you, Chris. So now we will move to, I think we'll try and do this in 2 sections to make it easier. Could we look at what we would like to think of as the positive steps forward before we look at the concerns? Could we talk about what we think is good about the consultation? Do you want me to start off? I've got a few thoughts myself. Thank you. Well, first of all, actually, before I launch in, I think it's really important to pick up on your last point, Avril, about it's crucial that we have easy to read documentation. And I know that in itself is a challenge, but I think it's key that everyone, a wider audience, even ourselves, gets the highlights from the improvement journey, and that it's very accessible and digestible. This was a hefty document, I understand, by the nature of it and its response and the importance of it. It had to be, but I would welcome a document that maybe we could share more widely if it were more of an easy read.
Yeah.
The other aspect of it in general terms that I thought was the documents so that there's two aspects to it. One is what is or has been ongoing but needs improvement, and the other aspect are new initiatives. So as I was reading through it, I was thinking what's improving from what we already had, which was important, and what is it to recognise as new. And I kept trying to separate out in my mind which was improvement. And what I think is important to state in the document, therefore, is that the improvements need to be noted as improvements. So when we talk, for example, in the section about the big conversation, the notion of a big conversation is new in a way in terms of its name. But I would like to think that we have already been conversing with people about all the different aspects of their healthcare. So I think that needs to be noted, that although to now we have been having conversations, we now are focusing differently and more purposefully in our conversations and our journey to improvement. And I think that when we talk about, family plans, care plans, family and patients involved, I think it's that we haven't done that before, but that we're just improving on that. Is that right to say? I'm trying to say that it's not as if we weren't doing anything before, we were, but we're sharpening our attention on these areas for improvement. And we have some strategies in there which will definitely help improve what we already had to a certain extent. That's the category, that's the definition I'm trying to describe.
Yeah, I think that's an accurate reflection. And I think it's also to say that, things that are new or have previously been in the account don't just drop off. We don't just stop doing or focusing on those key quality areas. It's just for the purposes of this document, we have to limit it to a certain amount in line with the mandated guidance. But we will, our quality approach is very broad, and the account can't in any way, provide oversight on all of that. So yes, you're very right in what you say.
Thank you. I've got a few more things, but I'd like to bring other people in if anyone else would like to say what they thought from reading it. David Coop.
Thanks, Chair. Yes, I remember from a previous health panel in Middlesbrough, we were told about staffing levels. You do mention people there. You mentioned about new patients, etc., being concerned in the past, etc. Are you happy with your staffing levels? Are you happy that you have enough staff and to take care of that? Because if you have a problem with a patient who may be new, do you have enough staff to take care of that and the rest of the people in there? Thanks, Chair.
Want to take that one, Sharon?
Yeah, I'm happy to take that.
Thank you. Thank you.
Yeah. So we constantly look at our staffing levels on a day-to-day basis across all of our inpatient services as well as our community, but main focus on the inpatients because we have to have a planned level of staffing, and we would increase that should there be any increased admissions or anybody who needs a level of observation that requires additional staff. So it's something that we look at on a daily basis. We are actually, like I said earlier on, around measuring ourselves against the MHORS 2, which is an evidence-based tool that looks at acuity levels. So we've been doing a piece of work where we will measure our acuity levels on a day-to-day basis and use that tool to demonstrate what staffing levels we actually need within our services. So we've been doing that now for a couple of years, and we are looking at our recruitment processes as well. So we are increasing, certainly within our adult mental health at the moment, there's a lot of investment in increasing our staffing establishments up based upon the evidence that we've got from the MHORS tool. So we're increasing the number of band 6s, We introduce an activity coordinator 7 days a week. We're looking at our ward administration processes as well, because it relies on the MDT to be able to provide good quality care. So it isn't just always about the nurses or the doctors, it's about the whole MDT. So we're looking at all of those people who are part of that process and making sure we do that, and we cover that over a 7-day period. And we also looking at practice development nurses as well, to make sure we're looking at the evidence-based work and audits, and they're outside of the numbers, but they are there to support us with the work moving forward to make sure we are delivering quality care. So we do look at staffing. We measure, we submit safe staffing details. We assess ourselves and our performance as well around that. And certainly in Teesside, we are managing well. Dominic might want to add a bit more to that, but my feedback.
Thank you, Sharon. Would you like to say anything on that, Dominic, please?
Yeah, thank you, Chair. I suppose there's a couple of things I would add around that. Firstly, I think one of the things that we've traditionally done is in terms of our establishments, if you look at those benchmarked across other organisations as part of national benchmarking exercises, our permanent establishments are probably relatively low in comparison to other organisations. And what we've tended to do is use flexible staffing, so bank and agency staff to support with that. One of the things we're absolutely doing is reversing that. So we're absolutely increasing the establishments as Sharon's described, because we know that actually in terms of that flexible staffing, whilst yes, that means you can move people to areas that you need them, there's also something about just having cohesive teams, and the quality of care will improve as a result of that. So we're absolutely focused on and doing that. And in terms of so our permanent establishments might look low in comparison, but when you add the flexible staffing in, it comes to the median that you see across the country. But we want to move away from flexible staffing to permanent establishments. I suppose we're talking a lot about inpatients. We've also seen significant investment in community services as a result of the development of the national policies like the Community Mental Health Framework for older people and adults, the introduction of things like a policy framework called I Thrive for children and young people services. But being perfectly frank, one of the challenges that we face is actually being able to recruit to the posts that we've got. And that's not only in terms of nursing, that's in terms of psychology and in terms of some medical staffing as well. And I think what we're seeing is, we're seeing some of the national, but there is a challenge around, it's great we've got the investment that's coming through, but actually we're having to be really creative about the way in which we go about recruiting and retaining staff to be able to support with that. So I think from a staffing point of view, it's kind of the desires there. It's absolutely about, is there enough of a market for us to be able to draw on? And I suppose that's all in the context of that, whilst we as an organisation are doing that, so are the mental health organisations around us doing that as well. So that, I wouldn't want to mislead you, that is a challenge.
Thank you, Dominic. Could I straight away then jump into our area of what we think is good, to put that challenge as one of our concerns, to support what you're saying, Dominic, that the recruitment and retention issue locally and nationally is a real challenge, and it's a concern that although we may have the funding, we might not have the people out there who can who are available to fill the post. So I think we should echo that in our report, that we are also very concerned about retention and recruitment of staff. And that's a very great concern, that maybe the courses aren't there to train people, that we're not recruiting to courses as well as to posts. I think that is a serious concern. Looking towards the future development, it's very serious. So I'd like to echo that, please, in our list. Shall we revert back to other members of the committees, what they think is good about this report, what they approve and we'd like to note? Has anyone else got anything yet?
Yes.
Well, while
yes,
who I can't see you. Who is it, please?
It's Councillor Cunningham.
Oh, hello, Councillor Cunningham. Sorry, I can't see your hand. Yes, go ahead, please.
Thank you, Chair. I have other questions, but obviously for the positives, I just wanted to say I have been pleased by the fact that the Trust have been listening to what people have said, that they have responded, that they have attended meetings, they have been, I feel, open and honest about the difficulties they're facing after their horrendous CQC report earlier this year. And I do appreciate that. It must be very difficult at this time trying to deal with this situation. But what I wanted to mention about was the Oxyhealth digital care assistant for preventing deaths and things. I'm really impressed with this, the fact that it's being used and that the monitoring of people in their rooms is helping to prevent people from trying to commit suicide. It's something I think is a very positive thing, and yet well, it makes things easier for the staff and for everybody concerned. But also I wanted to mention about the dialogue that you're using, the care plan. I know that one of the CQC concerns was the fact that that your care plans were not joined up, and there were different care plans being run in different areas of the Tees Esk and Wear Valley, and that this dialogue, if it's been introduced and it's a one thing fits all and that everybody's using it, I am pleased that that is actually being introduced, and it's a positive step forward to addressing some of the concerns that the CQC had. So thank you.
Thank you, Evelyn. That's really helpful. I would like to echo that myself. In fact, I was thinking, well, as a linguist, that in terms of even the notion of the big conversation, I think that says a lot about what this report is. It is meant to be a big, wide, extensive conversation, negotiation with all of the partners involved in this. So I think that is really good. And I'd like to underline my approval of the notion of a big conversation, and also the notion of our journey to change. As Evelyn just said, we are acknowledging the need to change by calling this a journey to change. And we are looking at the notion of that as a journey. We can't do all these things overnight, but we're really approving the fact that we're on that journey. We are making progress. It might be in slow steps, sometimes because of staffing issues, as Dominic just alluded to, etc. But I would like to say that we really do approve this notion of a big, wide consultation or conversation. And this is a journey to change, which we acknowledge we need to make, and we are making. So that's another aspect of looking at what the document's called and how we are making the changes. Anything else that we approve of? Anyone else like to contribute? I might not be able to see all the hands, please. So do call out if I'm not able to see you on the screen. Yes, Councillor Layton, please come in there.
Hello there. I'd like to just make a comment about the dialogue and personalising care plans. I remember when I started as a student nurse back in 93, 94, I think the personalisation of care plans was, was something that was old hat even then. I think it is something of a movable feast, and you learn, and things that you think are absolutely up to date and all embracing and sort of got the problem solved seem to sort of change as we learn more in all branches of nursing and care. So I think the fact that there's a sort of more joined up element about it really does make it more impactful. So it's something that I really approve of, and I wanted to echo other people's thoughts. I wanted also to pick up on something Dominic was saying about sort of the care, sort of reaching out into the community and things, and link it in with the work in preventable deaths, because a lot of work is done with preventable deaths, and to use a very sort of ham-fisted term, sort of near misses, where there's self-harm with intention to end somebody's life. That sort of incident that happens in a care setting is, I'm sure it's far easier to, actually sort of have notes about and sort of keep all the information and to follow up on. And I was wondering, do you link in as well with people that have sort of say have been discharged within 7 days of discharge, or people whose care is actually delivered within the community? Because I know from my limited experience of working in mental health, actually knowing of several people who calmly sort of bided their time while they were in a hospital setting, only to go home and to actually fulfill their intention to end their lives. So I was wondering, is there sort of provision in this monitoring to include people who've left care sort of and people who are getting their care out in the community? So thank you very much.
Thank you. Who'd like to answer that question? Is it Dominic, thank you, Dominic.
It's okay if I pick that one up, Chair. Thank you. So thank you for the question, Councillor. You're absolutely right. I think one of the things that might surprise people or may not is that we actually have more staff who work in the community than work in inpatient services. So we have a significant proportion of what we do is absolutely community delivered. In terms of that particular point around suicide prevention, we know that the evidence base is that the riskiest period for somebody in terms of the a high risk period for somebody in terms of the potential of committing suicide is absolutely when they're discharged from an inpatient setting and a psychiatric inpatient setting. And there's a national standard that's in place around that, which is that people should be followed up within. It used to be 7 days. It then moved back to 72 hours, and it's now moved back to 48 hours is the standard. And that's absolutely a standard that's in place in terms of the services we provide. So I think it's actually in the quality account in terms of, I think the national target is about 95%, and we are achieving that target. And I think the other thing I would add, it isn't just about one visit within that 48-hour period where people are assessed as requiring ongoing care within the community. They're absolutely supported into our community teams to be able to receive that support. And we've worked very hard on trying to make sure we've got the links between our community teams and our inpatient services to make sure that actually, all of that's in place before somebody leaves hospital. So where we have community staff involved with an individual, they'll be an integral part of the admission process and the admission plan. They'll take part in the meetings that are taking place on the ward in terms of planning the discharge process. So you're absolutely right. It's a really important point and something that I think we've absolutely got a good line of sight on. The other thing I'm just going to mention, just in terms of the care planning work. So I think there are a couple of things that are happening within the organisation, and I just want to be really explicit about it. So in terms of, as Councillor Cunningham mentioned, the CQC did raise concerns about where risk information and safety information was being held within the Paris record. So whilst dialogue will support the person-centred planning, from a risk and a safety point of view, we're not waiting for dialogue to be the answer to that. We've absolutely taken action in relation to that now. And what we've done is we've absolutely centralised all of that information, particularly from an inpatient perspective, which is around things in terms of leave plans for individuals, because not only is it a high risk period when people are discharged from hospital, leave periods are an area of concern and risk. So we've centralised all of the information on the system into a safety summary, which is kind of the description of the risks that might be around an individual that they're facing, be that in terms of harm to themselves, harm to others, neglect, etc. And that's all described within the safety summary. The safety plan on the current system brings together the leave plan, the engagement and observation plan, and other risk management processes that are in place to support that individual. And they are negotiated and discussed with individual patients, and also with their families and carers wherever possible as well. So one of the phrases that we're using a lot in the organisation is around safe today, safe tomorrow. So in terms of safe today, that's absolutely the work that we've done with our current system. In terms of safe tomorrow, that will be supported by the introduction of dialogue and systems like Oxyhealth and upgrades to some of our IT as well.
Thank you, Dominic. Councillor Layton, thanks for raising that. I think it's really important that Dominic was able to bring that to our attention. Do you feel reassured now in response to the responses?
Yes, I do, and I think it links in certainly dialogue and the sort of the tech obs for shorthand. I think especially when it's very easy to have good systems, but you really need to make sure that that people don't just think we've got that system in place and they can take their actually count on it to catch all. And I think the fact that it's all interwoven and you've got a safety summary that sort of almost like as a sort of net that links them all in together is very reassuring. And it's something certainly my colleagues who work in mental health will be very reassured about. But thank you very much, Dominic. I appreciate that.
Thank you, Councillor. It is not just a tick box exercise. I think we're all aware of that, aren't we? It's an ongoing vigilance and care and an oversight that we need to monitor closely and confer upon with all of the different agencies working together. So yes, I think that's really important to have noted that. Thank you. That's one of the things we definitely do approve of, all of the things that you've just described, Dominic, in terms of the all-round package of care over time, not only in the immediate. So, are there any other aspects of this report that we'd like to bring out that we approve of? Anyone else? Please call out, because I can't see all of the hands. Can anyone else see a hand or hear anyone? No? I think there's, I mean, it's just, again, things that have been mentioned, such as in the presentation. We want to really embed, you know, the safe care work streams with the metrics. We know we want to embed this at every level, and I think it's important that we highlight and recognise embedding is important, and at every level. It's not just one aspect of the provision. It's right across the board, and I think the embedding of it means that we constantly monitor and have oversight of it. We've just been saying, really, I was thinking along your lines, Councillor Layton, you know, we can't be in danger of just doing anything and that's over. It needs to be embedded across the system. So we approve of the fact that you are acknowledging that and going to press on with that. I mean, the compassionate aspect to me, you know, that we've got a people process which involves people with compassion, a person-centered approach. I'm sure we had that to some extent before. It's one of those things that I don't think we were lacking in compassion necessarily, I hope not overall. But again, it's really about embedding that and extending it, isn't it? That's another example of what we're trying to do, I think.
Could I just make a comment, Chair?
Yes, David, come in.
Yeah, no, I do appreciate what your comments about the staffing levels, etc. But also, what about discriminate between nursing staffing level and other staffing level? I'm pleased to hear what you said about people being visited. Councillor Layton pointed out if you have a problem and you go and visit them within 24 hours, etc., if they've come out. But what about nursing level? I know it's slightly different, but we were told at West Lane that there was one nurse on duty. That nurse was injured, sadly, and then there was no nursing staff on that. That was in West Lane. It's not everywhere. I just wondered how you look at that prospect and how you say we've got enough nursing staff as well as other staff in there that are capable of sorting those sort of problems out. And I'm sure you are addressing that. Thank you, Chair.
Thank you. Who'd like to answer, David?
So I suppose I'll start and then I'll come to Sharon. If that's
okay, thank you, Dominic, and then we'll move to Sharon's input. Thank you.
So Sharon's post absolutely is around assurance around staffing levels and quality of those staffing levels, and particularly nurses within ward environments. In terms of West Lane, we never had a position where we didn't have a nurse who was on the ward. I think there are challenges at times when we do have people who will ring in sick. But what we will do is obviously, you know, if we have absence at short notice or as a result of an incident, we will move staff from other environments to support with that. But I'll hand over to Sharon, who'll give you a much better description of the processes that are in place.
Thank you.
Thank you, Dominic. Over to Sharon.
Thank you, Chair. Yeah, just as Dominic said, we would never have an inpatient unit. It's a never event where we would have an inpatient service without a take charge shift with a registered nurse. So it's something that we would monitor on a regular basis, and we do have escalation processes should somebody phone in sick or some incidences happen. So we do have our staff escalation policies within the organisation. Those will be escalated, and we would look to make sure that we've got safe cover should anything go wrong. If there was any kind of, you know, we might have had situations in COVID where people have had to isolate, or there's been ongoing issues, but we've always been able to have like a contingency plan already prepared, or we'll have other people within the organisation who we can safely move and make sure that we've got that cover arrangement in place. We do monitor staffing, like I say, across our inpatient services on a day-to-day basis, across our learning disabilities and our mental health units. And we do report on that, and it is monitored because we're on electronic health rosters, so we can see we've got that visual line of sight around our staffing levels, and we can make sure that we don't fall below what our staffing level should be. Should any issues happen, like I said, those escalation processes would be there. If we needed to go into BCP, for example, if there was kind of COVID situations happen. But I think fortunately within Tees Valley, we've not had to implement the BCP procedures around staffing during COVID or anything recently. So yeah, it's regularly monitored. We've got that assurance. People do have to report on Datex anything that might be. So if staff feel unsafe, for example, because something unplanned has happened, they've got the ability to put an incident form or a Datex in, so we can have a look at that and learn lessons from that should that happen. But it is it's looked at proactively, and we can also, like I say, check our electronic health rosters to make sure that we've got that line of sight over our staffing.
Thank you, Sharon. Before I bring David back in, could you remind the panel what BCP is, did you say?
Sorry, business continuity plans. Business continuity plans, okay, just for everyone's information. David, are you reassured by this system of
Yes, I think so. I think that it was another event that happened that they said a nurse was injured at a particular occasion. This was a report that came back to the committee, and that there was a staffing problem on that occasion. But you have assured me, and I'm sure that it'll never happen again. Thank you, Chair.
Thank you, David. Anything else that we particularly want to mention as aspects of the report that are good, that we approve of strongly? Well, we could move on to the other aspect that we're considering this morning, which is our concerns. I mean, is it concerns about the report that you want, or concerns that used to exist that we now feel we've addressed? How do we want to exactly home in on this? Is it concerns of issues that the report might have missed? Is that what we're looking at?
Yes, Chair, I think that last thing you said is probably about right. It's about knowing what you know as local councillors about mental quality priorities. Do you think that we've missed something important, or is there kind of a nagging concern that you maybe want us to think about over the next few months when we're developing the next one of these? I think, yeah, really that's the focus.
Thank you. That's clear then. Thank you. I just was checking that's what we're considering now. So, would anyone like to make a contribution in the respect of what are our concerns about what may have been missed, or moving forward, what might yet need to be examined and scrutinised?
I've got my hand up, Councillor.
Okay, fine. Thank you. Go ahead.
Thank you, Chair. I had about three things I just wanted to actually mention. One was the actual size of Tew. You've got a huge geographical footprint, and it's got so different demographics throughout that period, and it does concern me that you're such a big organisation and that you're trying to cover such a huge area. The other thing I wanted to mention was the restraints on ward. On your metrics on page 64, they're still high for restraints, and I know in previous years you've said that the restraints were high because you had the eating disorder unit, but of course you've not got that now, and they're still high. I know that from reading your report that you're actually putting in extra training, but it is a concern to me that those restraints are high. And it's still on page 65, your metrics, it says about the attitude of staff not always giving dignity and respect to the patients, and that I think is worrying. So I'll be happy if you could actually answer those questions, please. Thank you.
Thank you, Councillor. Yes, we're on page 64 and 65 of the one that we were sent. There are a lot of red areas in there, aren't we, which I can understand your concerns, Councillor Cunningham. Would anyone like to speak to us about that aspect of the report? It's 64 and 65 on what we have.
Yeah, I wonder, Chair, if I come in initially around the size that you've
yes.
Talk a little bit about the restraints and the dignity and respect, but again, probably Sharon will be helpful in terms of describing, certainly in terms of some of the latter parts.
Okay.
So Councillor Cunningham's absolutely right in terms of the size of the organisation. It's enormous, and that does bring challenges in terms of So I think one of the things that we've struggled with over the years has been around attitude to variation. So we know variation in healthcare often leads to harm, but I think we've got to be more sophisticated in terms of our understanding of what type of variation leads to harm. So absolutely variation in terms of clinical standards and care delivery can lead to harm. In terms of variation around the way services look, the way they're configured, actually that's really important in order to be able to fit with your local system. So we know the way things are configured in North Yorkshire and delivered in North Yorkshire will look different and feel different. Well, certainly look different, hopefully not feel different, sorry. Will need to be different in comparison to, say, within Middlesbrough or Hartlepool or Redcar, Cleveland and Stockton. So I suppose I mentioned something, so there's a couple of things that we're doing around that. One is in terms of how do we absolutely make sure we've got those consistent clinical models, those consistent clinical standards, those consistent patient experience across the organisation. And we do that through using something called specialty development groups, which is absolutely part of the organisational governance structure. So they're responsible for setting the standards. The way we're currently organised at the locality level, and I think with some of the policy guidance that's come through more recently, so in terms of, I mentioned the Community Mental Health Service Framework, that's absolutely about being embedded in terms of local communities. So I would hope that people will probably remember that we've been here before to talk about things like right care, right place. And then more recently, we've been to talk about the Community Mental Health Service Framework. I would hope that people might have a sense from perhaps some of your council officers, possibly from some of the people that you engage with within third sector organisations, even individuals who use our services that may be coming forward to have conversations with you. We're very focused on trying to work at place. And within that, we've got an overarching Tees Mental Health and Wellbeing Alliance, but then sitting under that are all of the place-based mechanisms. So examples would be about how we've tried to engage much more closely within East Cleveland, which we know from a Redcar and Cleveland point of view was a concern about the kind of level of provision that was available in that patch. We're doing some very focused work now with the population health pilots in Middlesbrough, and we're very closely engaged with both Stockton and Hartlepool in terms of the development of those pathways of care and those models of service delivery. So in short, yes, it is a challenge in terms of the size of the organisation, but we do have strategies in place to try and support with that. And I think, you know, going back to what Avril was talking about and Chris were talking about in terms of our journey to change, the big conversation, that's absolutely developed us through. I think one of the keys when you're in an organisation this size has to be about simplicity. And I think the organisational goals that we've described, just the 3 goals, are incredibly simplistic for people to be able to engage with. I'm not saying they're simple to deliver, but they're simplistic and easy to remember and understand. And then I think the values that we're describing in terms of respect, compassion, responsibility, they're all of the elements that will support with some of that place-based work as well. And also will support with the 2 areas that were, particularly I suppose in terms of if I deal with the issue about people feeling that they're treated with dignity and respect. I think actually, you know, one of the things that we've absolutely identified is that in terms of the big conversation that did, in terms of the feedback that we got from service users and carers, particularly it highlighted almost kind of a large group of people who were saying that they were really happy with the care they were getting, but there was also a sizable group of people who said that they weren't. You know, that was a real challenge to the organisation about how we absolutely start to make sure we're engaging with everybody in a way whereby they feel that they're heard, that their opinions are valued, and their care is exactly that. It's their care. We're partners with them in that. And I think some of the things that we've talked about in terms of dialogue, person-centred care will absolutely go towards supporting with that. Also, the real push around our journey to change and that engagement with our staff in terms of those kind of core values underpinning everything we do. I'd also be remiss of me if I didn't say at this point that although we haven't hit the target in Tees in terms of that, I think we are performing well in comparison to other areas in the trust. So I couldn't help myself but to put that one in there. And then in terms of, so Sharon, I'll come to you to add anything to that you want to, but I wonder if I just finish off with the restraints on wards. So Councillor Cunningham, you've absolutely raised this before, and you're right to do that, because there's a couple of things around that. There's one in terms of obviously the experience of the individual on the ward who may be experiencing physical interventions, or those individuals within those ward areas. The other thing we have to be really mindful of is, you know, our staff don't come to work to physically restrain people. They come to work to provide care, to provide therapy, to provide support. Now, unfortunately, sometimes part of that care and treatment is around a physical intervention. But one of the what we're seeing is, you're absolutely right. So previously we had high levels of intervention that were related to the primarily the eating disorder ward within children's services. The overall numbers of intervention have come down, but they haven't come down as far as we'd want to at this point. And probably the area where we're seeing probably more interventions is within our learning disability service. And within that learning disability service, we do have numbers of individuals who've come from some, you know, we've had problems of our own, so I'm going to be absolutely honest about that in terms of our issues, the CQC, but we've also had some individuals who've come from some fairly high profile providers where they've been, you know, there've been issues in terms of the delivery of care in those environments. To some extent, that's part of the equation. But everything that we've talked about in terms of safer care, in terms of the development of models of intervention supported by positive behavioural support, etc., all goes towards moving us in the right direction. And I think one of the things that's interesting there is we're doing a bench within the report that we describe as we benchmark ourselves and against our target. I think interestingly what we're seeing is that nationally, certainly within things like our adult wards, etc., our levels of physical intervention are a lot lower than a number of other providers. And I think there's probably something about how we benchmark some of this against other providers as well, because I think there's something about recognising progress where progress is being made, but actually absolutely not sitting on our laurels, because we need to, you know, we want to get to a position where we just wouldn't have to use those forms of intervention at all. Sharon, I'll hand over to you if there's anything you want to add.
Thanks, Dominic. Thanks, Chair. I think you've covered most of the things, and I think it's just to really point out to people that we have seen a reduction in a lot of our services in the Tees Valley area, but we do recognise that our learning disability services still have that increase in physical interventions. But we do look at restrictive practices, and we look at physical interventions on a regular basis. We do have to report those out. We have our modern matrons who work within the inpatient services and community, who provide day-to-day support for services and looking at ways to improve things as well, and provide that assurance up to the trust. So I think it's very much on the agenda. We do look at this, and we do have our our positive behaviour support leads within our organisation that come in, which is outside of the clinics and ward numbers, I suppose, to provide some additional training and additional support. We've invested in our staff going on to master's level courses around positive behaviour support as well, to try and look at some of that evidence base. But it's very much looked at, very much monitored, and like Dominic said, we've seen a reduction in a lot of areas. We do know that our areas that are high, which is our learning disabilities. This month, we can see a reduction in our main bank fields in Middlesbrough. We can see a reduction in our restraints going down, but it does kind of go up and down, depends on the situation with the service users that are in the unit. Really complex. Thank you.
Thank you, Sharon. Thank you.
Thank you. Thank you very much.
Is that okay, Councillor Cunningham, that you are satisfied with those responses moving forward, that we will address these things? I think they are the big areas of concern, aren't they? The information that were provided on the quality metrics, that we would look forward to seeing those red change to green, obviously, and I'm sure that you're working hard on that, and that we look forward to seeing that report coming forward the next time that there has been that significant change.
Thank you, Chair. I'm encouraged by the reply. Thank you.
Okay, good. Thank you, Councillor Cunningham. Thank you. Are there any other concerns that we have in terms of omissions from the report, or things that we think may need to be addressed that haven't been addressed? Or
can I just come in, please, Chair?
Yes, of course, Dorothy. Yes.
I just wanted to speak to Dominic, really, because you've got huge challenges ahead of you due to COVID. Because I think the numbers are totally going to increase due to this, and I wondered how you were going to cover these, because they are going to increase. So you're trying to get things all right, but your numbers are going to increase because of COVID. Have you anything in place to deal with that at all?
Thank you. Dominic?
It's a brilliant question. So in terms of, and you're absolutely right, it is an enormous challenge. So we've obviously got a really clear focus in terms of the areas of quality we need to improve, but we're also trying to do that in the context of increased demand. So we are starting to see increased demand in terms of certainly our adult acute inpatient service, in terms of larger numbers of people requiring admissions. Our crisis resolution and home treatment teams, our urgent care services, have been seeing higher numbers of people from really quite early on in the pandemic. So probably around about the May, June time last year, we started to see increases in numbers of people presenting, and that's remained consistent since. People will be, children's mental health, people, pre the pandemic, people were becoming more aware of some of the challenges there. Pandemic and the lockdown has impacted that. So, we've seen for some young people, a bit of time away from school and some of the social pressures that were under there was good to a point, but actually it gets to a point where it's not helpful at all. And then for a number of other young people who would really have enjoyed the school environment and social contact, we've seen impacts there. And again, older people, we've seen, for everybody, we've seen issues in terms of kind of the people's access to social opportunities, people's access to socialization. For older people, where we know loneliness can really be a significant problem, we've seen that compounded again. So Chris, who's on the call, has led some modelling work that we've done within the trust, which is I've shared with the committee before and shared with various health and wellbeing boards, which has kind of described what we might expect to see over the next 5 years we're describing. And that's kind of built up of impacts across the life course, and also impacts in terms of different types of almost groupings of people. So, I've talked about life course groups, but then we also know there'll be the impact of trauma for people who've lost somebody as a result of trauma and bereavement, who've lost somebody due to COVID, trauma and bereavement for people, trauma for people who've been very unwell as a result of COVID, trauma for people, there's that long COVID is a term that's come into the language, and there are clear mental health and neurological impacts related with some of those elements. So absolutely, we're expecting a large increase in terms of demand for mental health services. I suppose in terms of the way that the things that we've put in place to try and address that, we've kind of gone at it in almost kind of, well, there's almost 2 or 3 ways to look at it. So there's something around in the short term. What was one of the things that we did was we expanded our range of crisis intervention services. We introduced the 24-hour-a-day crisis helpline that has been in place across Tees, which is across the whole of the trust, which is a free phone number, and people then can kind of access a crisis team if they require a home visit. But we've also attached to that what we call the listening service, and we're getting kind of well over 1,000 calls per month going to that listening service where people are requesting support. There's also been additional recruitment in terms of trying to make sure that we've got additional professionals, and particularly within the allied health professional network, to make sure that we're able to support with some of the different types of needs of people that we think will be presenting. So that's been kind of some of the initial response. In terms of the longer term response, which is built on the modelling, some of the things that I've talked about are really important. So there's something about what we do as an organisation, but there's absolutely something about what we do as a system. So what we don't know in terms of the modelling is who will present where and when, but we know with things like the community mental health framework that if we are far better embedded with our local systems, we'll be in a position to support people no matter where they materialise in the system. So there's a lot of work and investment going into the community mental health framework. There's additional investment that's come in this year to support the development of posts within GP surgeries. So I'm going to get technical, and I don't know how much this will mean to people, but for years we had staff within GP settings who then gradually replaced by something called IAPT, which is about improving access to psychological therapies. And actually, IAPT wasn't physically in GP surgeries. What we've seen with the community mental health framework is a return of investment to support some nursing staff to be based within those GP surgeries again. So actually, you've got nurses and GP surgeries, you've got IAPT for the psychological interventions, and then you've got kind of our secondary care mental health services as well. So that will all help in terms of being available to support people at a point of contact. We're working much more closely with the VCS, and a lot of money that has come into the system this year, you know, we've channeled some of it directly to VCS organisations and with the support of the local authorities, and made sure that actually, you know, we tried not to be scattergun in that. We've tried to work with the local authorities to be clear about what are the elements of their service provision and their commissioning that they're looking at in terms of resilience and well-being. So we've put investment into those areas as well. And I think in terms of the kind of core service provision, as I've said, it's absolutely about us kind of, you know, being really clear about evidence-based pathways, having the right staff available to provide that, but being far more embedded into local systems. Our children's services have done a lot of work in schools. There's additional investment to create mental health support teams in schools as well, which is really good. So I think in terms of investment and growth for mental health services, I think it is actually a really good news story at the moment, but that's in the context of increasing demand and increasing acuity, and it's in the context of some of those challenges in terms of workforce and recruitment. And I suppose the other thing that we really need to be clear about is from a health inequalities point of view, we know there are certain groups of people who access services and certain groups of people who don't. And so one of the things we're trying to be really clear about in terms of working with Health Watch in particular is around working with their community champions to work with groups of individuals who traditionally our services just haven't been appealing or accessible to, so we can start changing the nature of some of those. So that would include groups like refugees, asylum seekers, you know, for people who may be rough sleepers, in terms of some of the substance misuse work. So there's a lot going on, but yeah, the forecasting's been done, but you know what, actually we don't know whether that's going to be an underestimation, an overestimation, and I think we're kind of going to have to learn as we go along in relation to some of this.
Thank you, Dominic. Is that okay, Dorothy? I think it's we learn as we go along, as Dominic says, and see how this whole thing evolves.
Yes, definitely. And I think also Dominic touched on children, and I think it still affects now children, because I do know at our local school a whole year was sent home last week. So it's, and they're back online doing classes, and we don't know when it's going to stop, do we?
Yeah.
There's no end in sight at all. Thank you, Dominic.
And I think that makes it difficult to account for financially, doesn't it? To know the extent and range of the finances that are required and the staffing that will be required also as a result of the way things evolve. So we are challenged, I think, in that respect. Are there any more concerns? Councillor Layton, please.
Thank you, Chair. And it's just a question, something that cropped up over the past few weeks was we had a presentation at Darlington about the NHS's move towards social prescribers. And I wondered how that is possibly something for not this particular report, but maybe, you know, in a year's time, how social prescribers will sort of divert people. It's sort of almost like it's a triage where they're sort of taking people. Actually, one expression that sort of alarmed me was I heard that people who go and see their GP more than 5 times, who really just want to chat because they're lonely. I found it a bit sort of worrying, but I'm sure there is a sort of a logic and behind having social prescribers, but my worry would be that people might be going to their GPs with what they think is a physical ailment, and often GPs have in the past picked up on the mental health element of somebody's overall holistic health and been able to refer them. And if there is suddenly another layer of sort of people prescribing or sort of triaging potential sort of care service users, away from mental health services or off to charitable organisations or to some self-help group, have you got this in your sort of line of sight? Is it something that you're aware of, or that's something that might concern you in future, or is it potentially something that you see as a positive, because it's quite new to, I think it's something that they're trialling and hoping to roll out. Thank you.
Thank you, Councillor Layton. Dominic, would you like to take the answer there?
Yeah, so absolutely. So I think in terms of do we see it as being positive, I would say yes. I think notwithstanding the issues that you've described, but generally yes. So we know, particularly in terms of mental health issues, in terms of mental distress, we absolutely know that often, a lot. So we talk about a biological, a psychological, and a social model, or we used to in the olden days, and we know that actually social circumstance can have a huge impact in terms of somebody's mental health. So having that available at the point of, having that more readily available for people is a real positive. And we know that certainly things like exercise, etc., we know there's good, strong evidence base in terms of the positive impact that can have in terms of people's mental health and well-being. But you're absolutely right. If somebody came with a serious mental health issue with associated levels of risk, etc., then you wouldn't want them being diverted away from mental health services. And I think this is where, the GPs will still have oversight and contact with those individuals. But I think also those PCN staff that I talked about, the primary care network staff, working actually in the surgery will enable them to almost become part of that team, part of the team of the GP, part of the team of the social prescriber, and hopefully they will be able to use each other as appropriate to meet the needs of the people that are presenting in front of them.
Thank you, Dominic.
Thank you.
Is that okay, Councillor Layton?
Yep. Thank you. Yes, it is.
Thanks for that question too. Are there any more concerns?
Just to add to that, Chair.
Yes.
I mean, a lot of people could fall through the cracks in the pavement here. The people who have had a bereavement, I've had one myself, and who may not ask for help, but do need help. I think there'll be a lot of people out there who don't visit the GP surgery very often, don't call for help, but do need it. And I just don't know how you would address that as a problem, whether you would, I mean, some surgeries don't do well man, well woman clinics, etc., etc. So people have not been seen by surgery for a number of years, apart from perhaps a COVID jab. Shouldn't we be looking at that as a problem now, as a health authority, and as a thing that people out there could be wanting help, but they're not crying for it, but they're needing it? And how would you address that? Because that could be a big problem further down the line. Thanks, Chair.
Thank you, David. Is it Dominic again, please?
Yes, I suppose so it's a big problem now, not even necessarily down the line. So I suppose one of the things around mental health systems is that historically that there's the level of need within the population, which is called prevalence. What we know in terms of mental health systems is that historically the proportion of the prevalence that converts into demand for mental health services is actually really low. And the reasons why that's really low have been about I say really low. So internationally, we're probably talking about, in some cases, I've worked in a country where the proportion of demand from prevalence was as low as 5%. In the UK, we're around about kind of the 30% mark, maybe slightly more, I think. And actually that shows the UK to be one of the highest performance systems in the world from that point of view. But what influences that has been the availability of services in terms of access. And, mental health services have historically been a bit of a Cinderella service. I don't think that's the case anymore. You know, and there's been a real recognition of the need for that, and that's led to things like, you know, national initiatives like parity of esteem. The other thing that really impacts in terms of, well, the two things. One is mental health literacy, so people realizing that and understanding what's happening to them and understanding they need a little bit of help, because sometimes people have other language and will frame it in other ways. And then the other thing that really impacts is stigma. So people not wanting to come forward to look for help because of the stigma that has historically been attached to mental health issues. So I think in terms of the way that that can be addressed, so I think from a, you know, the departments of public health that are working within all of the local authorities have absolutely got a key role in that, in terms of the well-being and the mental health literacy initiatives and anti-stigma campaigns. I think there are other things that we can do. So, you know, not everybody by any stretch of the imagination has social contact, but lots of people do. And that contact, there's something around making sure that where you are coming into contact with somebody, no matter whether they work for the fire service, whether they work for a voluntary sector organisation or a mental health professional, everybody's got just kind of a baseline level of knowledge and can perhaps start to see where some difficulties may be arising and offer some support, advice, you know, and bring services in as appropriate. And I think that's going back to the system conversation. I think that's going to be something that we're really going to have that focus on making sure that actually when we think about workforce, we're absolutely thinking about everybody who's involved in either VCS, statutory services, health or social care, to be able to kind of, you know, recognise signs and activate help where that's necessary.
Thank you, Dominic. Does that answer your question, Councillor Coop? You feel more reassured?
Yeah, I do. I think as long as you obviously do realise what's going on, but I think a lot of cases out there, the people, you hit the nail on the head when you said the stigma. If people think, hang on, if I say I've got a mental health problem, oh dear, I'll be told I've got a mental health issue and you know, it could affect my job, etc., etc. So it's getting over that preconception, if you like, that if you have it might be a temporary mental health problem, it might be an underlying health problem. It's better to address it now than address it 6 months, a year, 2 years down the line. So it's getting over that and saying they're getting over that idea of a stigma. It isn't. It's there to help, and I think that's very important. And I think you do absolutely address that correctly. Thank you, Chair.
Thank you, David. Thank you, Dominic. Are there any more concerns? Could I just raise one that may not be within the remit and scope of the report? And it's related to the question and consideration that we had about geographical extensive areas within the Tube. One of the main aspects concerning all of this, to me, is poverty and deprivation, and the analysis that we could well have for different areas within our wide community where mental health and other health issues are more prevalent. And you know, they are related often, as we know, to poverty and deprivation. And do we really, are we entitled to have any analysis of that in terms of impact of poverty, certain areas, as opposed to the whole big geographical? Because I would think that some problems are centred more in some areas than others, certain types of problems, health, mental health, etc. I don't know if it's within the remit of this or if it's possible to have a further analysis of poverty and deprivation aspects and health issues.
Chris, do you want to come in? Were you on mute?
Apologies to members, sorry, rookie error. To give you some reassurance, CCG mental health funding is actually partly based on weighted population. So, for example, it's recognised that the demand for mental health services in Teesside, if you like, per person will be greater than the demand in, for example, North Yorkshire and York. And so Tees Valley CCG get more money for mental health per head of per actual person than North Yorkshire and York do. You know, as with all weighting systems, whether it's weighted enough and whether it could be better, yes, I'm sure it could be. But there is that within the system. The way that we're set up operationally, we respond to where the need is. So we do that as best we can. I know our public health colleagues continue to do some quite good work around, you know, where when the need is greatest. So very occasionally there are things which aren't correlated with poverty. I mean, a good example is child eating disorders, where actually it tends to be that it's more affluent areas which have the greatest demand for those services, but that's a rarity. Generally, Chair, you're right that the more deprived an area, the more mental health issues there tend to be. But of course, not everybody who is in a poor and deprived area will have mental illness. Not everybody who is in a so-called well-off area will be mentally well, because there's lots of other things which can trigger both resilience on one hand, but mental illness on the other. And I know Dominic's probably a bit more of an expert than me on this, so he may want to add to that.
Thank you for that. Dominic, do you want to add anything to that in terms of our insights into how that pans out in any respect?
Dominic and the phrase expert have never been used in the same sentence before. So I think probably, I mean, in terms of your request, Chair, I think it was around whether you can kind of almost get sight of what are the levels of deprivation, what does that mean in terms of what we understand the impact of that would be in terms of well-being, as Chris has said, but also in terms of how that then develops into mental health issues or not. And that's exactly the piece of work that our public health departments are working on at the moment. So I probably need to go in and have a chat with Mark Adams and with Sarah in Stockton and Craig, just in terms of kind of a timeline, perhaps to bring something back to share with people, if that's okay.
That's absolutely fine, and I would very much appreciate that. I think other members of the panel might well appreciate some insights into that aspect of the issue that we're facing generally, because of the variation within our geographical area. It's quite significant, isn't it? And
I don't work in Darlington, but I'll absolutely make sure we link in with
yes.
Director of Public Health in Darlington to present, include them within that presentation.
Okay, that'd be really helpful. I think it's my special request, and as I said, it might be without the remit of, outside the remit of this particular report, but I'm interested that Public Health is actually looking at that anyway, so that was quite a timely question without knowing. Are there any other things, any other issues that anyone would like to bring up before we close the meeting? I'm looking for voices or hands. No? Can anyone else? I don't need to deprive anyone of a contribution. Caroline, we've got to finish the meeting on the agenda, but I just meant on this aspect. Were you worrying there, Caroline? I was just going to end it there.
Oh, Caroline,
you're on mute, Caroline.
Sorry, Chair, I'm not used to Teams, we're used to WebEx, sorry. Yes, I was just going to say, Chair, obviously members have had an opportunity to have a great discussion today about the quality accounts document and the areas that they feel should be highlighted within the statutory response we provide to the quality accounts document. So I was just going to say, obviously, I've made notes during that discussion and will capture or attempt to capture the highlights and put that in some sort of succinct letter that addresses the issues that we need to respond on and have that back to Tube by tomorrow evening. So I'm just conscious that I'll probably send that out either later today or first thing tomorrow, because I know we've also got Middlesbrough Health Scrutiny later today. So it might be first thing tomorrow, and then I'll just be that I need approval back from each of the authorities, if that's okay. So just to raise that with members and check that that's okay with Tube as well, as the next step in this process.
Okay. Would everyone approve that we will quickly, I mean, thank you, Caroline, for very quickly, in your case, putting together 1.5 hours discussion nearly into a letter. I think that's your special challenge for the day, and we wish you good luck with that. I'm sure you'll do an excellent job in representing our views. So thank you in advance for that piece of work, Caroline. Is that okay with everyone else, that we get a response back to Caroline in terms of the letter that she writes in that it reflects what we've discussed today?
Yes.
Thank you. Thank you. Is that okay with everyone? Yes, thank you.
Thank you.
That's great. Thank you. So at that point, have we any other business for this agenda? It's point 8 on the agenda. No, thank you. And the date and time of our next meeting. Would you like to remind that, Caroline, please? And hopefully we'll have full attendees from the different authorities.
Yes, Chair, I think it's the 24th of September.
That's right, I think that's right.
Yeah, by which point all of the local authorities should have appointed all 3 of their members to represent them.
Thank you. Is that okay with everyone? Thank you. We've got that date. So I think on that note, I'm looking round meaningfully, seeing if I can see anything I might have forgotten. I would really like to thank all members of this panel today for their presentation, for the questions on the presentation, which have been excellent. And I think they've been thought-provoking and helpful, hopefully helpful to everyone concerned. Thank you to all of you for the responses that you've given, which I think have been very reassuring in every aspect of the questions where we've had our worries. I feel that we've been reassured that things are ongoing and moving. So thank you very much, everyone. Sincerely, thank you. Thank you for your attendance and have a lovely rest of the day. Thank you. Goodbye.
Thank you.